So fellow Tennessee physicians, thank you for joining us tonight to discuss the role of the Tennessee Medical Association in providing a voice for physicians in these troubled times. My plan for this evening will be to give some general information about the TMA and how this organization can give voice to our concerns as physicians. Afterwards, I plan to answer questions from you from the chat box and emails about your concerns and interest in making your physician voice heard. With the cancellation of the second part of the TMA House of Delegates due to the pandemic, my hope tonight is to share with you some of my thoughts and goals as your TMA president and to hear your concerns and interest in getting more involved to make your voice heard. My format will center around the word voice. First, why do we need a voice as physicians? Second, how can TMA represent our voice as an organization? Third, how can you get involved to make your voice heard? Fourth, how can you contribute to make our voice stronger? And fifth, how can you encourage your colleagues to join us to broaden our voice? And finally, I want to hear from you about what issues you care about and discuss how to provide more opportunities to express your voice in our organization. For those of you whom I have not met, my name is Kevin Smith, and I'm honored to serve this year as your TMA president. I'm a Mississippi native and attended Ole Miss for college. I came to Nashville to attend Vanderbilt Medical School and graduated in 1993. I practiced as a general internal medicine specialist and primary care physician in Nashville for the past 24 years. I've been on the full-time faculty at Vanderbilt for the past 10 years, and prior to that, for 14 years was in private practice at St. Thomas West Hospital, including 6 years running my own solo practice. I have been very involved with my state specialty society, the American College of Physicians, and my local medical society, the Nashville Academy of Medicine, serving as NAM president in 2018. I've also been involved in teaching Vanderbilt residents and medical students my whole career. So V is for voice. Why do we need a voice? How can TMA be our voice? What happens if we do not use our voice? Well, as a physician, I've witnessed a constant decline in physician autonomy and increase in administrative burdens that certainly does not appear to help me take care of my patients, and instead creates new burdens and hurdles to jump through in daily practice. I decided to get involved because of the trends to question our advice and plans, replace us when possible with non-physician providers, and limit our abilities to fund our practices. Our profession is under attack, and if we do not stand and make our voice heard, we will likely continue to suffer more unnecessary obstacles in doing our job taking care of patients. When I started my practice, I spent most of my time listening to my patients and considering what was best for them and what the best plan for them would be. Now I spend more and more time interacting with an EMR and checking endless boxes and messages, worrying about prior authorizations and getting the right code for everything, as well as the increasing cost of medications, both new and old, for my patients. Physicians need to have a voice, or those who regulate our care will continue to make that care more difficult to provide. We can all agree that 2020 has been quite a year thus far, and the coronavirus and other events highlight the need for us as physicians to have a voice and influence for our state and our patients. The pandemic arrived in Tennessee on March the 5th, and in the over 200 days following, over 180,000 Tennesseans have been tested positive for COVID, and over 2,300 have died. Coronavirus certainly indicated a need for an organization to work with our government, including our governor and county mayors, in guiding their decisions during a pandemic. And TMA was there from the start, first advocating for the shutdowns to buy us time to get PPE and capacity, then providing guidance about safe reopening strategies, mask mandates, liability protections, and increasing PPE supplies. We may not have always been the most visible externally, but we have maintained direct contact with our state leaders. And while they did not always follow our advice, at least we were at the table providing information to help. We have a COVID information resource on the TMA website and outlining executive orders and providing guidance on dealing with the pandemic. The people of Tennessee need us as the voice of medicine in the face of a public health crisis. We have posted maps on our website showing numbers of new cases per 100,000 people per day averaged over the last 7 days for anyone to see how their county is doing. In these maps, green is less than 1 new case per 100,000 per day, yellow is 1 to 5, orange is 5 to 10, red is 10 to 20, darker red 20 to 30, darkest red 30 to 50, and black over 50. So I thought I would run quickly through our weekly maps, illustrating the coronavirus pandemic in Tennessee. Since these maps are averaging cases over the prior 7 days, every Tennessee coronavirus case is represented in these maps. Our first case was reported on March 5th in Williamson County, and a man who had flown to Boston and back to Nashville. Davidson, Shelby, and Sullivan counties quickly followed. And by March 18th, Nashville and Williamson counties had over 1 new case per 100,000. And this was about the time the SEC basketball tournament and the NCAA basketball tournaments were canceled. By March 30th, TMA was asking Governor Lee for assistance in acquiring PPE and testing supplies and requesting a disaster declaration. And on March 24th, Tennessee physicians, including TMA members, sent a letter to Governor Lee asking for a statewide shelter-in-place order. By March 27th, TMA sent a letter to Tennessee mayors recommending them to issue stay-at-home orders. And on March 31st, Governor Lee signed an order urging all Tennesseans to shelter in place until April 14th and close non-essential businesses. And about that time, we had our first outbreak in a nursing home in Gallatin and Sumner County. On April 3rd, Governor Lee strengthened his stay-at-home order to be an order and not just an urging in response to TMA and other Tennessee medical societies. And Nashville reached over 10 new cases per 100,000 per day, along with Sumner, Trousdale, and Grundy counties. On April 14th, the TMA had worked with Governor Lee to extend the stay-at-home order until April 30th. But on April 17th, Governor Lee granted APRNs and physician assistants in Tennessee the ability to practice without physician supervision during the pandemic. At the same time, TMA legislative staff was meeting with Representatives Robin Smith and Dr. Brian Terry discussing passage of a telemedicine parity bill. By April 22nd, the TMA was offering guidance to Governor Lee and the Economic Recovery Council regarding safe reopening, recommending a county-by-county approach based on the number of recent cases. And we saw the first prison outbreak in Bledsoe County with over 50 new cases per 100,000 per day. On April 24th, Governor Lee issued orders for phased reopening, and TMA was working to get elective surgery and non-essential procedures restarted. On April 28th, Governor Lee announced non-essential procedures would be allowed starting May 1st. We saw more prison outbreaks. On May 1st, TMA issued guidance for safely performing outpatient and non-essential procedures, and we joined with other businesses in a coalition seeking COVID liability protections. On May 6th, TMA sent a membership survey out asking how COVID-19 had affected our practices, and we sent Governor Lee guidance on safe reopening of medical practices. By May 13th, many Tennessee counties still had less than 1 new case per 100,000 per day in green on our maps. And statewide case growth had only increased from 4.01 on April 1st to 5.13 new cases per 100,000 on May 13th, indicating the value of the shutdown in slowing the spread of COVID. By May 15th, TMA and the Business Coalition had drafted legislation for liability protection. And on May 19th, Governor Lee allowed his order that provided unsupervised practice for APRNs and physician assistants to expire. By May 27th, we started seeing increases in cases in Nashville, Chattanooga, and Putnam counties. And by June 3rd, we started seeing more cases develop in Middle Tennessee and in Memphis and Chattanooga. And we continued to work with the reconvened General Assembly on the telemedicine, balance billing, and COVID liability protection bills. The Tennessee House and the Senate passed 2 differing bills regarding telemedicine with pay parity on June the 2nd. We withdrew our balanced billing bill on June 9th when it was clear it was not going to pass this year. And by June 17th, as Tennessee continued to liberalize social distancing and reopening, more rural counties started turning orange with over 5 new cases per 100,000 per day and red with over 10. On June 19th, the General Assembly ended session without acting on the telemedicine and COVID liability bills. And on June 23rd, Governor Lee announced Tennessee had the most active COVID cases since the start of the pandemic, and we reached over 10 new cases per 100,000 per day in the state. By July 1st, Tennessee had more than 30 new cases. By July 1st, Nashville had more than 30 new cases per 100,000 per day, and Middle Tennessee started turning redder on our maps. And on June 30th, Governor Lee extended the state of emergency through August. As July progressed, we started getting darker in many counties, and Nashville had more than 50 new cases per 100,000 per day, and Tennessee had more than 20 new cases. As a frame of reference, at the peak of the pandemic in New York City, they reached 56 new cases per 100,000 per day in April. Sevier County started seeing cases rise with the return of more tourists, and Nashville started enforcing a mask mandate that had been issued at the end of June. We really started getting darker red by July 15th. On July 9th, TMA had issued a letter to Tennessee county mayors urging them to issue mandatory mask mandates, especially in counties with over 10 new cases per day in red or darker on our maps. On July 14th, Governor Lee announced his intent to call a special session in August to deal with the COVID liability and telemedicine bills. By July 22nd, 25 Tennessee counties, including Memphis, Nashville, Chattanooga, and most of Middle Tennessee and Upper Cumberland, had over 30 new cases per 100,000 per day. And TMA was working on drafts for COVID liability and telemedicine bills for the special session in August. By July 29th, Tennessee as a state had over 34 new cases per day per 100,000, and all but one county had over 10 new cases per day. Many counties in West Tennessee had over 50 new cases, along with Sevier County. On July 28th, TMA started sharing our county new cases maps on our website for anyone who wanted to use them. And the peak of the pandemic in Tennessee thus far was around August 1st, with over 36 new cases per 100,000 per day. At its peak, New York State reached that number in April, around that same number. By August 5th, the number of new cases were starting to decline, especially in counties with mask mandates, and this decline continued by August 12th. West Tennessee and Upper Cumberland continued to have many new cases, with most of their counties without mask mandates. And by this time, TMA had worked with county mayors to get about 70% of the state under some type of mask mandate. On August 18th, TMA was successful in getting both our telemedicine with pay parity and our COVID liability protection bills passed by the special session. And by August 26th, new case rates in Middle Tennessee and Memphis were declining, while West Tennessee and Upper Cumberland rates remained elevated. On September 1st, Governor Lee issued orders extending the state of emergency until the end of October. And new cases statewide by September 9th had decreased to less than 20 new cases per 100,000 per day, with great improvements in East and Middle Tennessee. Knox County started seeing more cases after the reopening of UT. And last week, many cases in many counties were again on the rise, likely related to schools reopening. On September 15th, we were invited to be part of the Tennessee Department of Health COVID vaccination stakeholder meetings, and I attended the first meeting on Tuesday of this week. By this week, we continue to see steady cases statewide, with fewer cases in urban counties and more cases in rural counties, especially in West Tennessee and Upper Cumberland. While we are gradually trending down in cases, this will take a while, and we will likely not have much yellow or green on the map until we get a vaccine and start getting higher levels of immunity in the community. Well, in addition to COVID-19, we have witnessed the tragic deaths of George Floyd and others that highlight the need for continued change in how we treat each other and the need for more understanding and love for our fellow man, regardless of race and ethnicity. And on top of all this, we are in the middle of a very divisive election year in which we will have to make decisions concerning how we will proceed going forward as a country. Our patients and our leaders look to us for advice and guidance as their trusted physicians, and we need to make our voice heard. O is for organization. So what is the TMA? What are local medical societies? How is the TMA organized, and how can we be more organized to represent physicians' voice? So the TMA was founded 190 years ago by 47 physicians who rode across Tennessee on horses and drove carriages to Nashville for the inaugural meeting of the Medical Society of Tennessee on May 3rd, 1830. These doctors personally knew Congressman Davy Crockett and President Andrew Jackson, who was in his second year as President of the United States. Their fathers had been pioneers, and they had trained in the best medical schools of the day before coming to Tennessee to practice medicine in a frontier state. Their purposes were similar to ours today: improving the health of the people of Tennessee through promotion of scientific knowledge, and regulating the practice of medicine by examining candidates and their qualifications to be physicians. They met annually, except for 4 years during the Civil War. They dealt with epidemics of cholera, yellow fever, malaria, influenza, especially in 1918, and tuberculosis. And they promoted clean water, vaccinations, improved sanitation, mental health, and care for the less fortunate. They started medical schools and training programs to prepare the next generation of doctors. They advocated and created a state licensure program and the Board of Medical Examiners. They promoted the highest ethical values among their members and provided for disciplinary actions for those who did not comply. They federated with other state and specialty associations to create the American Medical Association in 1847. And we have had 7 TMA members elected AMA president, most recently Dr. Thomas Nesbitt in 1978, and hopefully we will have another AMA president from Tennessee soon in Jesse Ehrenfeld of Nashville, who was AMA board chair last year. Our forefathers recognized the importance of local medical societies and reorganized in 1902 as the Tennessee State Medical Association and created a House of Delegates, where each local county society sent elective representatives as their voices to debate and deliberate policy and directions for the profession. So what are local medical societies? These are the independent local component societies that are the bedrock on which TMA is based. There are 4 large metro medical societies that have independent staffs and affiliated foundations. The Nashville Academy of Medicine, which was founded in 1821, the Knoxville Academy of Medicine, founded in 1853, the Memphis Medical Society, founded in 1876, and the Chattanooga-Hamilton County Medical Society, founded in 1883. There are also 26 smaller component and county medical societies managed in part by TMA staff. And the local medical societies are a great place to get your voice initially heard. Attending local meetings with CME events, holiday and president's receptions, legislative receptions and dinners with lawmakers. The local medical societies elect the delegates to the House of Delegates. They get members to the Day on the Hill to meet with local representatives, and they support our local medical student and resident fellow section events. How is the TMA of today organized to give physicians a collective voice in our state? Well, we have over 9,600 members, 4,400 active dues-paying members, 1,200 retired physicians, 2,200 resident and fellow physicians, and 1,800 medical students. We are organized in 8 regions that elect trustees and judicial counselors. We have a statewide election of our president-elect annually. And we have the House of Delegates, which serves as our governing body and which meets annually in the spring, composed of 171 elected delegates from local medical societies, 17 representatives from state medical societies, and 56 current officers and past TMA presidents. We have very strong membership sections in our medical students section, which is organized in chapters at all Tennessee medical schools and has been very active at Day on the Hill and in proposing legislation directly. and they have a medical student leadership summit annually. We have a resident and fellow section with over 2,200 members, and the resident fellow section is hoping to plan some specialized events with topics like joining a practice, student debt and financial planning, contract negotiations, and legal reviews. We also have had a young physicians section that I hope to revive in the weeks to come or months to come, which has currently been inactive, but this would include physicians under 40 years of age or less than 8 years in practice. There is TMA board representation for this section if we get enough engagement and membership. So the TMA Board of Trustees manages the organization between House meetings and is composed of 8 regionally elected trustees, the 3 statewide elected presidents, the president-elect, and the immediate past president, the Speaker of the House of Delegates, the resident and fellow section representative, and the medical student section representative. We also have a judicial council of 8 regionally elected counselors to resolve disputes. And we have several committees, including legislative, insurance issues, public health, membership, professional relations, education, impact, constitution and bylaws, and our AMA delegation. Our TMA staff is led by CEO Russ Miller and includes 22 staff members divided into areas of legislative, insurance, education, operations, physician services, and communications. We have an over $3 million budget, and I just wanted to show you where the money comes from. On income, notice that we get 62% of our income from membership dues directly, and our expenses, 26% completely goes toward advocacy, while 15% goes for member services and marketing. So despite the pandemic, we had a great year advocating for Tennessee physicians and patients. With regards to scope of practice, we led in the creation of a coalition for collaborative care consisting of leaders from state specialty societies to consider changes in the collaboration rules with the APRNs and PAs. We met with the Tennessee Nurses Association and Tennessee Association of Physician Assistants for almost a year to propose compromise rules regarding less chart review with experience and time working with a physician. The Tennessee Nurses Association rejected these compromises and introduced a bill for independent practice without requirement for physician collaboration this year. And we had already suggested allowing for even 0 mandatory chart review after 3 years in practice for new graduates or 1 year for an experienced APRN in collaboration on a physician-led team. The TNA bill was rejected in House Health Committee without a vote or a second, but the TNA will likely file a new bill in 2021 after that short period of unsupervised practice by Governor Lee in April and May during the pandemic. We also have defeated in repeated years a proposal to allow physician assistants with a new doctoral degree to practice primary care independently. And we expect new scope challenges from optometrists, psychologists, pharmacists, physical therapists, and others attempting to practice medicine more without physician collaboration. So in addition to working on scope, we worked on our telemedicine with pay parity bill, which requires payment parity for telemedicine and a recent in-person relationship and visit with a Tennessee physician. And this will give us 18 months to show the legislature that this will be a great benefit for Tennesseans, especially for those in rural areas. The COVID-related liability bill provides some protection against frivolous lawsuits arising from limitations in care during the coronavirus pandemic. And the TMA also continues to advocate for a balanced billing measure, which prevents insurance companies from limiting provider networks and then setting the prices of services for out-of-network physicians. And this will continue to be debated next year. TMA also advocated for elimination of the professional privilege tax in Tennessee for physicians, and this might have been passed if it weren't for the financial implications of COVID on our state government. In recent years, TMA has been successful at getting an additional $8.7 million in funding for GME for primary care residency spots. And also we're concerned about possible GMA funding formula changes that might be looming in 2021. We have continued to defend malpractice reform measures that were passed years ago in court challenges. And the most important of these require a physician expert to review any case brought forward in Tennessee. And we have limits on damages, which has made the practice of medicine much less litigious in our state. We continue to work on episodes of care, and we got a pause on that this past year, and we continue to work for improved access to care. And our metro medical societies have project access programs that they advocate for uninsured specialty care. We've also encouraged all our members to be engaged in the current discussions around diversity and racial disparities this summer. Even prior to this year, one of TMA's strategic goals has been to increase diversity in membership and leadership. We are planning on creating a diversity advisory group of some sort and increasing our educational offerings concerning bias and racism. And we are working with our local medical societies and our sections to provide meetings and focus on these important issues. On June 11th, we released our statement on racism and health disparities in an attempt to verbalize how important this issue is for all of us, especially as we take care of a diverse patient population and mitigate the effects of social determinants in their health. We continue to work on programs to encourage physician wellness and prevent the growing problem of physician burnout. Between our local medical societies, which have programs to support us, we also support the Tennessee Medical Foundation, which provides programs for impaired physicians. And they have provided a confidential online screening questionnaire for anyone to take confidentially at e-tmf.org/TNPSQ. I think the importance of connection with other members of our profession is very important in preventing burnout and promoting physician wellness. And we could think about perhaps some type of mentorship programs and career planning sessions that help us as we go along in our careers. I think there's great satisfaction in knowing that you're making a difference for your profession above and beyond taking care of your patients. And so I think we can do a lot in the terms of physician wellness and burnout. So what else does TMA do? You can see this long list of other organizations that we're affiliated with, including TMA Physician Services, TMA Alliance. We have our own Institute for Physician Leadership. We support the Tennessee Medical Foundation and the Tennessee Medical Education Foundation, which provides scholarships for medical students. We help start SVMIC, which is the State Volunteer Mutual Insurance Corporation, which provides malpractice insurance for most of our non-employed members. And we provide legal and insurance issues for members, CME educational programs, and medical student and resident fellow section support. So I is for involvement. How can you get involved and make your voice heard in TMA? How can you make a difference? Basically, think about getting involved as much as time allows. Start with your local medical society to meet your colleagues and talk about the issues. This is a great place to get involved without having to commit more time and travel. Local events, like we had mentioned before, are great times to meet others and hear about the issues of the day. There are lots of other opportunities for involvement, and I'll just run through a few of these. Think about spending a day with our legislative team at the Capitol as Doctor of the Day. Try to get to know your legislators and let us know as part of our grassroots effort so that we can contact them when we need them to vote a certain way. Consider representing your local society at the House of Delegates at our annual meeting. Think about serving on committees of interest. Think about doing the physician leadership program. Think about forming special interest groups about key issues that come up. Think about attending our Zoom and membership meetings, and we're planning on having Zoom meetings for discussions every third Thursday going forward. Certainly try to vote in the TMA leadership elections, participate in surveys, and just stay informed with emails, updates, and our website. C is for contributions. Membership dues are a great contribution, and we certainly appreciate all of you who are actively dues-paying members. And being part of an organization that represents your profession is a great way to use your money. Also can think about contributing to Impact, which is our political action committee, which supports candidates for office who will help our profession as we care for patients, and also encourages and supports physician candidates for office, which you could also consider. Our local medical societies have foundations that provide project access programs for the uninsured and educational programs for communities. And time is always the most valuable and precious commodity that you can contribute. And finally, E is for encouraging your colleagues to join TMA. There is strength in numbers, and more members mean a stronger voice. The TMA has approved new discounts for new members in 2021. These would be new members who are paying individually, including new resident and fellow graduates, with 25% dues the first year, 50% dues the second year, and 75% dues the third year. This is a great way to ask your colleagues to join without having to commit such a large amount to an organization they are not familiar with. Certainly encourage your practice leaders to support TMA memberships in your groups. Encourage medical staff leaderships to give time at meetings to discuss TMA membership and benefits. And ask your leaders to encourage and support TMA memberships for hospital staff. And think about hosting a local medical society meeting for your colleagues to get to know what TMA does at your location. And one challenge I have for each of you, ask at least 10 colleagues to join TMA this year. By increasing our numbers, we will be able to engage a younger and more diverse group to represent us and contribute to our voice. So you're probably tired of me hearing me saying voice over and over again, but this is how we make a difference and create changes for the betterment of our profession and our patients. In summary, we have a great organization and which can do much more to provide a voice for our issues as physicians taking care of patients. All we need is you and your colleagues to strengthen and broaden this voice so that we can be heard. If we do not stand up and speak, we cannot fault our political leaders and others for their actions, which are influenced by other groups, such as insurance companies, trial lawyers, non-physician associations and schools, pharmaceutical companies and PBMs, and all the others who seek to control and regulate us further. In the end, we need to focus on our patients and for us as we take care of them. That is why we chose to practice medicine in the first place, and that is what the TMA is dedicated to fight for. Thank you for being a part of the TMA, and please make your voice heard as we travel through time together. And now I have talked enough. What issues do you want to discuss, and how do you want to make your physician voice heard? I'm going to open up to any questions you've provided on the chat function or online and try to cover as much as we can in the time remaining. If we do not get to your question during this time, we will do our best to answer it in the days to come. I'm also planning on sending you a survey in the near future to identify what issues matter to you the most and how you might want to get involved to make a difference. So with that, I will start looking at the chat function. And we do have some email questions that are as well. So we will go with that. And some of you may have issued some questions on the question and answer session too. So we'll look at that as well. So the first question that I see on the chat function was from Perry Rothrock. Can we mandate that everyone with a coronavirus or flu see a lawyer and legislature before we will agree to see them? Well, maybe that would be an effective strategy, and I appreciate the primary care terrorist comment from Dr. Rothrod. You know, we've seen masks are effective, and certainly we wish we could convince our population and our leaders that this is the best way to slow down the coronavirus. And you know, one would only wonder what would happen if everybody wore a mask when they're in public. could the coronavirus maintain itself like it has? I think the maps show that the numbers have gone down differentially in the counties that have had mask mandates versus those that haven't. But obviously, we can't, we have limitations on what we can dictate to our fellow citizens. And so, I guess we just have to keep encouraging and educating, and we certainly can push the county mayors to continue to push the governor to allow them to use the mask in their locations. So another question, let's see. Oh, this is another question from Dr. Rothwork about large groups, and it seems that engaging doctors who are in large groups sometimes is difficult, and we need to think about that. I think when we have a large group, the onus is on us to try to engage those members and convince them that even if their group is paying their membership now, what we'd really like to see is that if the group decided not to pay their membership at some point, that they would want to continue on with us as TMA physicians representing their profession. So we need to keep working on that. So another question, what is TMA, from Dr. King, what is TMA's position on the Medicaid waiver conundrum, and what alternative plans would have a chance to pass in the state legislature? Obviously, this is a very difficult question in our state. Our Republican legislature has been very resistant to Medicaid expansion, and now has the waiver that they've requested. My understanding is the waiver is held up due to the coronavirus, and so we're not likely to get an answer on that anytime soon. And of course, the bigger question is going to be, how do we divvy up who controls the money, what services are we going to go for? I think this is a robust area that TMA needs to be at the table as we determine how to take care of patients under this waiver, if it is ever provided to us. Let's see. So Michelle Griffith has asked about the telemedicine bill and what a great victory that was to get pay parity through April 2022. The TMA is already planning efforts to gather, and she asked if we're already planning efforts to gather data and to support continued parity after that date. I think that's exactly what we need to do, and I appreciate Dr. Griffith and her efforts with telemedicine thus far at Vanderbilt. I think that we're definitely going to need data, and we're going to need data that not only indicates what we've done for patients and what kind of services we've provided, but also what locations those patients have been in. One of the big arguments for expansion of scope, especially in the area of primary care by nurse practitioners and physician assistants, is that we're not able to provide services adequately in rural counties. I mean, with telemedicine, we can really expand our reach of services, and perhaps physicians can impact care in rural counties directly in conjunction with nurse practitioners and physician assistants who are there. And and as I talk about the scope and the nurse practitioners and the PAs, keep in mind these are our colleagues, and we need them to help us as we take care of folks. The only thing the TMA has been opposed to is them doing it without our collaboration or input. They didn't go to medical school. They haven't had the experience of a residency. And a lot of times they've done online courses with very limited clinical experience. I think we all agree that they would benefit from having a physician that they're collaborating with to run questions by and to consult about patients before they just ship them off to the ER or to a consultant, or try a treatment that maybe they don't completely understand the effects of. So let's see. Next, I've got Dr. Kreiner. What will be our continued efforts at the state and national level to mitigate the looming ban on balance billing? Well, at the state level, we're going to continue to advocate for our balance billing bill that we proposed last year, or something very similar to it. Our bill allows for some sort of mediation or some sort of ability to mediate to use an arbitration or mediator process to pick the actual payment, and not let it be just whatever the average insurance payment rate is. And we would like it if that would be based on some sort of benchmark, so that we have a way to compare and a way to make sure we're getting fairly paid. You know, if our networks if the insurance company network gets really small, you know, if they only have like 4 providers in a hospital, and they've lowballed them so that their average rate is very low, the average payment rate is not going to be the way to go, because they'll continue to drive that downward. And so we've really got to make sure that we use some of the language, that we try to adopt some of the language that I think it was in Texas that their bill had, and there was one other state I can't recall right now, and language that some of that the House plans in the Congress provided for national balance billing, as opposed to some of the Senate plans. Unfortunately, one of those was sponsored by our own Senator Alexander. And so we got to continue to fight this, because if insurance companies start to get to set the rates, it'll just be one gradual decline in reimbursements and our ability to do stuff for our patients. Let's see. Valerie Arnold says we should encourage our members to be part of the COVID vaccine trials to help dispel the myths. Now, this is going to be a big challenge for us. And I can tell you, as from our meeting on Tuesday with the COVID COVID stakeholder meeting, we're going to really have to overcome a lot of the misinformation and just fear about the vaccine, both that it's going to cause terrible side effects, but also that it's never going to be enough, and we're always going to have to wear a mask. And, you know, it's just, there's so much unknown right now that I think we've got to be careful as physicians to admit that we don't know what's going to happen next, and that we are going to, you know, watch and see. We have to get a safe vaccine that's effective, and then we're going to have to convince patients to take it. I'm going to try to convince mine to take it, hopefully they'll be able to relax their mask and their social distancing. And I think if it does turn out to be that sort of thing, then we'll have a lot of folks that are just tired of wearing masks and tired of dealing with the pandemic. So, but we will have to work on that quite a bit. And TMA will be providing guidance, I'm sure, on how we're going to, help our patients through this time. Let's see. This question, can TMA reach out to big employers in the state of Tennessee to ask them to reconsider coverage via Blue Cross Blue Shield for their employees, because Blue Cross will not cover infusion services for cancer, GI, and rheum infusions? As we are certainly, Dr. Huffstutter is our legislative committee chair, and this is an issue near and dear to his heart, the challenges on getting infusion therapy and the problems with white bagging and that sort of thing. And we're going to be at the table. We're going to keep working on that side, on the insurance side. As far as the big employers, I don't know. We could think about how we might reach out to them, because they could certainly put a lot of pressure on Blue Cross Blue Shield. But you know, a lot of that comes down to what the going rates are. You know, a lot of employers want the cheapest rate that provides the services that their employees will accept. And one way is to continue to work on our patients and let them know, that there is a reason why they need to be in certain networks and why they need to have us as their physicians. Let's see. Don Barlow asked about the Knox County Board of Health feeling threatened by their local health officials, and it seems to be a national problem that has trickled down. Doesn't that speak a lot to where we're at as a country right now? You know, science has gone completely out the window as this virus is, and everything about it has been politicized on both sides. You know, I just think that all we can do is provide our guidance and our opinions as physicians. And it has grieved me greatly that apparently no one really thinks that we know what we're talking about. You know, we know about viruses. We know how viruses are spread. We know a lot about how this is going to go, about pandemics of the past. But yet, since it's become such an issue about personal rights and of course we know we couldn't have stayed shut down forever. Our businesses and our economy couldn't have tolerated that. But hopefully we won't get to a point that when we're providing sound medical advice that we're actually being threatened in our own in doing so. And all I know is to keep trying to be as apolitical as possible as we're providing our advice. And certainly the TMA needs to continue to message and provide guidance to all of our membership and to our patients about you know, some of these myths and some of these you know, challenges going forward. I mean, it amazes me that people still can't understand that wearing a mask is a way to protect your fellow man, you know, rather than something you're doing to protect yourself. And it is disappointing that we haven't been able to convince a large population that that's the case. But I think we're seeing more and more masks, and I think with time, we're seeing the number of cases go down, at least in certain parts of the state. Certainly would like to see more of that in the rural areas. And then Leah Jesse, who is our Leah's our resident fellow representative leader, I think. Are there any legislative items related to reducing racial healthcare disparity that the TMA plans to be involved in this year? I think that's a great question, and we need to carefully think about where would be the best place to put any efforts that we have. You know, obviously, making sure everyone has access to adequate care is going to help across racial lines. You know, certainly, many of our citizens are stressed by their position as a diverse group. We need to think about this more, and I would welcome any of you to consider forming some focus groups or consider what solutions you might propose. And that's one of the good things about the House of Delegates is when we come together as a House of Delegates, which we didn't get to do this year, but we're hoping for April. You know, members can bring resolutions to try to convince your colleagues of important items. And that's one way that things get started at the TMA and that we move forward. But I think it's a great question, and I wish I had a great answer. But I just think we've got to continue to understand that a lot of our fellow residents don't feel comfortable and feel like that they are in a disadvantaged position, and also the fact that they're you know, a lot of times incomes are lower, jobs are harder to keep, family situations are not ideal. The drug problem is preying upon them disproportionately higher, and of course coronavirus is disproportionately affecting our minorities. So great question, something we need to keep thinking about. Dr. Kreiner's asked, the nurse practitioner lobby is getting more aggressive by the day. Unfortunately, the battle has been lost in many states around the country. What is the specific plan for TMA to fight to keep the physician as the leader of the medical team? Is compromise our only option politically? Well, one of the reasons why I think the nurse practitioner bill failed so quickly in the legislature this year is that the lawmakers were aware that we had attempted compromise with the nurses. And we went a long way, maybe further than we should have gone in some people's mind. But we kept it that it was about the team, that it was about a doctor working with a nurse in collaboration. And the doctor would determine how much independence the nurse could have based on their experience working with them. Obviously, the nurse practitioners didn't like that idea at all. They think they're fully trained to go out and practice independently from basically day one. I mean, keep in mind right now, they only have to have 20% of their charts reviewed. So 80% of the time they're basically practicing without oversight. But, you know, we're gonna try to leverage the compromises that we proposed last year as a coalition and make sure the lawmakers know that we've come to the table and that we tried to compromise. I'm not sure that I think they want the whole thing. I don't think they're going to accept our compromises. So we'll see. But that's if we need to propose some sort of regulatory change, if they're going to practice medicine, they probably should be under the board of medical examiners instead of the board of nursing, or maybe some sort of joint board combined from both sides of those two groups. If they're going to practice medicine, we need to make sure they're practicing it safely. And we just have a fundamental difference on what safely means and what level of experience you need to be able to practice medicine without some sort of collaboration or oversight. All right, I'm going back to the chat box now. And let's see. Dr. Denaney, our past president, mentions that the TMA has developed a relationship with Insurance Commissioner Mainda, and following up with Karen Baird and Natalie Dixon, who chairs our insurance committee, and then we're also working with pharma in terms of white and brown bagging. We've actually started a pharmaceutical council with several leaders of the pharmaceutical companies to talk about these issues. And I tell you, the pharmaceutical companies are concerned just as much as we are about these attempts by the insurance companies and the PBMs to put more hurdles on patients and barriers on patients trying to get the care that they need. So yeah, we're continuing to work on that. It is high on our list. Let's see. Dr. Bono has posted, and maybe we can post this for everybody, about a podcast talking about how masks can help others and help the wearer of the mask. So we'll try to get that posted for everybody to be able to see. Dr. Rothrock wants us to point out that the lawyers in the state donate 6 times as much to their organization as we do. The lawyers of the state probably have significant resources on a per person basis, but we do too. And it just goes to the fact that if we don't stand up, nobody's gonna protect our ability to practice medicine or take care of our patients. And it would be a shame for a profession as noble and as long lasting as ours, and our presence in this state to be diluted because of these other organizations that have more money. I can tell you our legislative team does a great job, and despite our challenges as far as revenue and monies go, we get the most out of what we've got, and we use our impact money very carefully. But of course, if we had more to donate to candidates, it seems that the legislators certainly put a lot of stock in folks that have supported them financially as they make their decisions. And so I would encourage everyone to donate to impact and to continue to stay involved and make sure that we have a place in it. And I'll tell you, I went down to the state capitol a lot, and they will listen to you when you're down there in person. At least they pretend they seem to listen to you. And they're in a tough spot too. You know, they don't understand all these things that we do. And I really feel like our role is not only to have our lobbyists educating them, but for us to go down there ourselves and help to educate our legislators. And I've never had a bad experience. Sometimes they push back if they really feel like that we're probably being a little hard on the nurse practitioners. But you state your case and talk about the experience and the education. And really, it's about being on a team. It's not us versus them. It's wanting to keep nurses with us on teams. You know, one of my quotes was, as long as doctors and nurses have been working, they've been working together. So there's that. Dr. Barlow asked, is there a way to contribute to impact on an automatic reoccurring monthly basis? I think that's a great idea. And I think we will work to try to see if we can't set that up, just as we've set up our dues. You know, you don't have to pay your dues all at once a year anymore. You can have an automatic monthly withdrawal or quarterly withdrawal to make it easier to get those dues in. Well, I think we've probably taken as many questions as we can fit into the hour, and we're almost up. Just my word is thanks. Thank you for all you do and for your support of the Tennessee Medical Association. You are all heroes, and the TMA is here to support you. And if I can be of any assistance in my time as TMA president, please send me an email at kevin.smith@tnmed.org. I am honored to lead this organization, and I hope you will join with us as we stand together for our patients and our profession in the days to come. Good night, and God bless you all, and stay safe and wear your masks. All right. Take care. I appreciate y'all joining with us.